Hypokalemia is the big killer in DKA. We are on day 3 of our tips in DKA management. Today we're going to be focusing on potassium. And all patients coming in with DKA are going to be total body potassium depleted. And I already know what you're saying, Swami. I have seen patients in DKA with potassiums of 6 or 6.5. Hell, I've seen patients with lethal dysrhythmias from hyperkalemia who also have DKA. That's because the severe acidosis these patients have shifts potassium out of cells into the serum, but they are still total body potassium depleted. If the patient has life-threatening hyperkalemia, you're going to treat that as you normally would, with the exception of don't try to eliminate potassium from the body. For all other patients, we want to keep a really close eye on the serum potassium, understanding that many of the treatments that we're going to bring to these patients are going to drop the serum potassium further. The biggest culprit, of course, is insulin. We want to hold our insulin drip if the potassium is less than 3.5. Replete the potassium, start the insulin drip after the potassium's over 3.5. If the serum potassium is between 3.5 and 5.5, we can start the insulin infusion and the potassium repletion simultaneously. When I'm starting that insulin drip, I'm usually skipping the bolus. Bolus plus drip doesn't close the gap faster, doesn't resolve the DKA faster, but it increases the risk of the patient developing hypokalemia. There are cases where a bolus is going to be necessary. We're going to address that in another reel.